Good morning. I am Phyllis Sharps from the School of Nursing, and I'm very pleased to introduce this first panel of the morning. And what we are attempting to do with this panel is to examine the relationships between residents and health status, and particularly strategies at the neighborhood level that could be associated with improving health outcomes. I'm very pleased to introduce the distinguished panel members, and I'm going to introduce all of them together, and I would encourage you to look through your conference materials for a more detailed description of the accomplishments of these distinguished panel members. And after I introduce them as a group, they will come individually in the order that I introduce them to do their presentation, and then we'll follow up with some questions and answers. Our first speaker this morning is Dr. Barbat, who is the Commissioner of Health for the Baltimore City Health Department. Secondly is Dr. Jonathan Ellen, who is a professor of pediatrics at the Johns Hopkins School of Medicine and the president of All Children's Hospital Foundation in St. Petersburg, Florida. This hospital is one of the sister hospitals in the Johns Hopkins system. Dr. Stephanie DeLuca, associate professor of sociology at the Johns Hopkins Zager Krieger School of Arts and Science. And certainly not least, but Dr. Troutman, the president of the American Public Health Association. So we'll start with Dr. Barbat.
Good morning. I'm a little height challenged, so can everybody see me? All right, excellent. It is a pleasure to be here today, and it's actually a little bit surreal to be here following Sir Michael Marmot. So I want to thank Dr. Blum and the conveners of this symposium, and I'm going to stick to my 7 minutes. So I'm from New York. I can talk fast. You all are from Hopkins. You can listen fast. So this is a map that illustrates all of the liquor licenses in Baltimore City. And by the end of 7 minutes, you will understand how it is that we're using evidence-based practices to reduce alcohol outlet density and violent crime in turn. Excuse me. Current liquor board regulations say that we should have 1 liquor license for every 1,000 residents in Baltimore. We actually have more than twice as many as that. In order to get a comparable ratio of health promoting outlets, we would need to have 30 times as many supermarkets and 4 times as many parks to get to a comparable ratio. And if we're going to have truly health promoting communities, it shouldn't be easier to walk to your nearest liquor store than it is to walk to your nearest supermarket or park. There's good public health evidence that's robust and consistent that demonstrates that high alcohol outlet density is associated with high rates of violent crime. And so the situation in Baltimore has resulted from basically 2 laws. 1955 law prohibits liquor stores within 300 feet of a church or a school, and the 1971 zoning code that eliminates off-premise liquor stores in residential and neighborhood commercial zoning districts. So what actually happened as a result of that was 2 things. One is there were what we call Class A licenses that were grandfathered into the zoning code, and that created monopolies in certain areas. And the second thing was that there was lack of specificity on tavern designation, allowing a significant percentage to function actually as de facto off-premise outlets, and we call those the BD7s. And so the impact on Baltimore City was that these establishments are disproportionately concentrated in African American census tracts. And so I'm not going to touch the clicker because I might mess it up. The slide here shows, the base of the slide shows poverty rates, so that those that are the darkest blue illustrate communities where greater than 20% of the residents live under the federal poverty level. And the red icons, both squares for the Class A, triangles for the BD7s, indicate those businesses that are non-conforming businesses. And you see that they are concentrated in the areas of the city with the highest rates of poverty. They also, based on data that we did through our neighborhood health profiles, have the shortest life expectancies, the highest homicide rates, and the poorest health outcomes. And through our neighborhood health initiative, we engage communities in our neighborhood health profiles, and I encourage you all, if you haven't seen them, to check out our website, baltimorehealth.org. You can also find Healthy Baltimore 2015, the city's health policy agenda, that really talks about the social determinants of health and how where we live, work, learn, and play affect our health more so than direct medical services. And we engaged the community in these conversations, and we had them prioritize the 32 indicators within Healthy Baltimore 2015. And in half of the council districts, they ranked liquor outlet density as one of their top 10 health concerns. And primarily because of this simple fact. This slide illustrates it's the same businesses, but the base of the graph is now violent crime. And you see that the darkest areas have the highest rates of crime, and the lightest areas have the lowest rates of crime. And so for communities, the density issue is as much about crime and quality of life as it is about health outcomes. And so part of what's going on in Baltimore through Transform Baltimore is using the zoning code to promote and protect community health. It's an evidence-based health and all policies approach to addressing violent crime in the city. It's a measure that's endorsed by the U.S. Task Force on Community Preventive Services, WHO, Surgeon General, a wide number of institutions. And there are 3 specific provisions within the zoning code that address reducing alcohol outlet density. One is addressing the issue of the Class A's, so that's amortizing the non-conforming off-premise outlets. The second one is clarifying the definition of the BD7 so that we don't have as many de facto packaged goods stores. And then the last one is enforcing the 300-foot limitation on new liquor stores with the exception of downtown. And so this process of Transform Baltimore, a partnership between the health department, the planning department, and the legal department, engaged a number of community residents throughout the city. We had significant citizen input as well as business input. And a bill was introduced in April. It's going before city council hearings, before city council 4 hearings. We anticipate the end of the summer, beginning of fall, and it's got the support of our mayor. And so this, we anticipate, will significantly affect violent crime in the city, but it's difficult to predict by how much. The primary effect on violent crime, currently, each 1 unit increase in the number of alcohol outlets is associated with a 2.2% increase in the count of violent crimes. And this is through work done by our partners at the Bloomberg School of Public Health. Jackie Jennings et al. Submitted this for publication in the American Journal of Preventive Medicine. It's difficult to predict how much the decrease in density will affect violent crime because of the fact that this is not the only measure that we're taking to reduce violent crime. At the same time, the mayor's Vacancy to Value program, a blight transformation initiative, is also taking place in these same communities. Additionally, the secondary effects on other health outcomes is to be determined. Literature also demonstrates a correlation between rates of cardiovascular disease, STI, HIV, behavioral health, alcohol consumption-related morbidity, and mortality. And so I am going to end my presentation in a similar way that I began, with a map. And so this map looks only at the businesses that are Class A's, and it demonstrates the residents, percentage of residents within a quarter mile of a Class A establishment. And you see here that 59% of everybody who lives in Baltimore lives within a quarter mile of an off-premise alcohol outlet. And that with amortization over a 2-year period, what you see here is opening up of space. And looking at the areas in the west and the east where the concentration is the greatest and where the health disparities are the greatest, my hope is that when you look at this slide, you think about the possibilities that open up with the degree to which we can reduce just the Class A's. Unfortunately, the saturation with the BD7s and the conforming is such that there's still a high concentration of liquor outlets, but there will be hopefully slightly less so with this zoning code. And so as I meet my 7-minute mark, the final thought that I want to leave you with is that right-sizing the concentration of alcohol outlets in urban centers and decreasing the associated violence, crime, and health disparities in our communities affirms the importance of equity as we preserve and enhance the long-term public and economic health of cities like Baltimore. Thank you very much.
A little taller so I can move the microphone up. Good morning. Never time to wake up, stand up, shake up. My life was made easier because the same maps apply to the work that I do. And actually, some of that work brought us together. And I think I didn't know what I was going to say. Actually, I didn't know what I was going to say, but I want to break from it and say that the kind of work around the liquor stores that is going on, I remember our first conversation about it. And we were hemming and hawing and trying to figure out, who we could affect and who would listen to us and how we'd go through a very slow process. And you just looked at us and said, no, we're going to do it. And we're just going to figure out how to change, who is not conforming. And we're going to use that as a lever to change what's going on in the city. And I thought that kind of bravery is what we were talking about, that it takes to take action and really just say what is the right thing to do. For those of you who don't know me, I'm a sexually transmitted disease researcher. I study sexually transmitted diseases in part because it's a fun topic, but partially because it gives us insight into social determinants of health. Sexually transmitted diseases are easy to diagnose and they're easy to treat. So there's really no basis for there being such great disparities or distances between people who get them and they don't get them. We have in this city 2 of the premier STD clinics that you'll find anywhere. And unfortunately, they're both sitting right in the center of where our largest problems are with sexually transmitted diseases. They're free clinics, so you can't say there's an access problem. We have good treatment, so there's no problems there. Yet we do have these incredible disparities in sexually transmitted diseases in the city. So the question comes up, is this an issue about people? And I think one of the nice things, and the reason I studied sexually transmitted diseases, is that when I first started doing it, everyone said, well, this is an issue of promiscuity. It's a great word. It labels people, and people are happy to say it's their problem. It's not ours. And what you start to recognize is that when you start to adjust for differences in number of sexual partners, condom use, and all those things we talk about that we call personal responsibility, we still see an incredible difference in the rates of sexually transmitted infections, both by race, ethnicity, and by social conditions. I can show you, and there's been a lot of great work that's been done over the last 15 to 20 years that have demonstrated, the same way these maps demonstrated how liquor outlets and violent crimes are related, how space is related to STDs and sexually transmitted infections. And what you recognize is that those neighborhoods where they exist are different than the neighborhoods where they don't exist. And those neighborhoods, and this is the other part of the map that we always get to, and I think Bob once pointed this out to me, North Avenue. If you look at sexually transmitted infections in Baltimore, they have their biggest plumes sit around North Avenue, south of North Avenue. And North Avenue was the line in the city where people were not able to get mortgages if their skin was not white. And so what you see is that segregation created these areas in the community where people could not move out of. And what I think our work has shown, and looking at what leads to sexually transmitted infections, it's particular spaces in particular places. If you add on to that the concept of segregation that historically has been in Baltimore, or had been in Baltimore, you start to see how people cannot escape these particular factors that we know are place-based that cause disease. Liquor stores being one of them, drug markets, open-air drug markets being other ones. And so what you start to see is that we have these structural features that went on in this city and still to this day continue to go on in the city that segregate communities. And when I give this talk as part of an academic lecture, I talk about separate and unequal. I talk about the difference between choosing to live somewhere and the kind of communities that you can shape and control, and what happens when you don't have choice, what happens when you can't move out, when you can't go elsewhere, when you start as we look back to the housing subsidies that we were looking at in London, what happens when your opportunities are restricted? And that's a form of segregation that we're talking about. And that creates unequal environments, and those unequal environments create unequal health outcomes. And so what do you do about that? And I think that you have to start looking at this in a micro and a macro way. And when we talk about the fact that the mayor of London actually took on what was a socially progressive policy or approach, you start to recognize that you have different levers at a local level than you do at a state or a national level. I work in Florida, and I can tell you I can get more progressive action out of a deeply conservative legislature than I can get out of Washington, even with my own leaders who would be blue to the core. And the reason is because local people have to take local action. And I think there's nothing to be, I think there is really where our steps need to be taken. I think the health department to take on liquor stores is exactly right. I think what we have started to do in the HIV STI world is to talk about working with communities to have them take on local control of what they're doing. Make policies, work to change policies, help to rebuild houses, help to do things on a very local level, because actually, as much as we like these macro level policies, the people who care are local. And so I guess my only take home message is STDs are a local phenomenon. They need to be fought locally, and you need local engagement. So that's my time. Thanks.
Good morning. I'm glad to be able to share some of the lessons I've learned with you today based on about 15 years of sociological research I've done with students here at Hopkins, looking at the role of housing in neighborhoods and how it affects family and child well-being. So I've been doing this work with my doctoral students, my undergraduates, and some collaborators in 3 cities, in Chicago, Mobile, Alabama, and also in 4 cities, actually, and moving to Dallas and Cleveland this summer. And we've been spending a lot of time in homes, churches, communities, searching for housing and talking to families and visiting with them. So in part, what I want to talk about is sort of the role of social science research in helping us understand some of the determinants of health and some of the possible policy levers that we have at our disposal. I do a lot of mixed methods research, so I work on randomized controlled field trials, also a lot of ethnographic and field work, and I try to take the lessons from this work and share them with local media foundations and also with folks in Washington, which is one of the nice things about being here in Baltimore. I spend a lot of time with families trying to understand how they make ends meet and struggle with the constraints of low income and the trauma of living in some of our nation's most dangerous communities, sort of how they try to raise their children and put together a life, and sort of what some of the barriers are to doing that, and what we can be doing a better job of. And I want to thank the families that have spent time with me over the years, and some of their photographs grace these slides and with their permission, and I want to thank them and thank you for giving me a chance to share their stories and make good on the promise I always make them when I do the interviews, that I'll take their stories around and share them. So we're talking about health today, but I also want to remind us that there are other phenomena that are affected by living in low poverty or high poverty communities. Education is one of them, which is also really highly correlated with health, especially later in life. So the stakes are high, not just for health, also but for things like education and employment. Just to give a few examples, growing up in a neighborhood of concentrated disadvantage reduces the verbal cognitive scores of African American children equivalent to that of missing a year of schooling. This is when compared to their counterparts in the same city not growing up in disadvantaged communities. And the negative effects of living in neighborhoods of concentrated poverty accrue over time and can have devastating consequences for their odds of graduating from high school as well. So I've spent a lot of time looking at interventions, whether they're class action lawsuits or federally funded demonstrations, to see what we can do about this. And in the 1990s, the Department of Housing and Urban Development launched a 5-city experiment to address some of these problems and see what would happen if we offered over 4,000 families the chance to participate in a program to move from inner city public housing projects to lower poverty, more affluent, safer communities. While challenges remain and all problems weren't solved by relocating from poor neighborhoods, we learned some very important lessons from this experiment, which was called Moving to Opportunity. One of them, most strikingly and surprisingly to many people who don't actually spend time in these communities, but not surprisingly maybe to many of us, is the improvement in mental health among women who escaped poverty and among their female children. And the improvements in mental health for the experimental group in this trial were on par with our best practices in antidepressant therapies. There was also a reduction in extreme obesity and diabetes and increased levels of subjective well-being equivalent to that of earning another $25,000 a year, according to some of my colleagues in economics who've done this research. There was also an increase in housing quality and safety, a significant reduction in neighborhood poverty, which led to some of these things, and an increase in access to higher quality schooling. So this gives us a sense of what's possible. Although the program did not increase employment and educational outcomes, we learned that there's an incredibly important lever in housing in neighborhoods, something that we can incorporate into our policy package. So I'm not going to go through slides with coefficients and graphs, but I'm going to show you subjectively what this is like for the families who experience this. So imagine waking up in the morning and this is what you see outside your window. Some of you may recognize some of these houses in Northwest Baltimore. So imagine then if you had a chance to wake up in the morning and see this instead. So this is not super scientific, but the research I'm talking about is. I just wanted to give you a sense of what this is like. And then to talk about what the voices of these women, what it was like to experience this. So Tammy says before she left the neighborhoods in West Baltimore that are now demolished, actually through the Hope 6 program, she explained to us that was the worst experience I ever experienced, living in an environment which made you feel trapped, caged, and worthless, just stuck in an atmosphere of absolutely no progress. It was a whole little community of pure dissatisfaction and everything. No one encouraged no one. Rachel said, but see, that's one of the things that allowed me to continue to use drugs, because I was always looking at people that was worse than me instead of looking at people who were better, that were doing better than me. After escaping these neighborhoods, women like Nisi told us a really different story. She said, once I left, I could see grass, I could see trees and birds and squirrels, but in the project, it wasn't nothing like that. I'd moved from night to day. The project was not clean. And you know what? It gets better. I can see it's going to get better. And Amy said, so moving up here, it's a whole different atmosphere, the greenery. You living in a high-rise, you get a lot of cement. And there's something to that effect in the psychology, the hardness you get from all of that concrete. The greenery, it softens you. It's so beautiful and peaceful, the space. So these are some of the accounts from women who on average experienced significant gains in mental health, and for some of them also physical health. So how can we provide better opportunities for families to get access to the kinds of communities that could help improve their well-being? So there are certain policy and market obstacles to this right now that we can certainly act on. Some of you are familiar, as was mentioned by the other two panelists, about housing subsidies, and right now we have a couple of ways we do that in the United States. One of them is through the provision of in-place public housing units, which are becoming less and less common. Another way is by giving housing choice vouchers so that families can take their housing subsidy and move somewhere else. But there are a number of barriers for those families to get access to the best kinds of houses, best kinds of neighborhoods in the area. Some of this has to do with the fair market rents that are set in these policies. Source of income discrimination. It's not illegal for landlords in most of the states in this country to discriminate against families who are using a housing subsidy. This has been up in discussion right now in the state of Maryland, and I was talking with some reporters about this recently. It was not passed, unfortunately. There are also just limited housing provisions in general, a lack of counseling for families who'd like to access better neighborhoods and schools, and a series of issues with landlords which go unaddressed generally in our public policy that we can do a much better job of. One of the things I've worked on is a program in Baltimore that's a desegregation remedy that came about as the result of a class action lawsuit here in the 1990s that gives us a window into what we could do better. And so families, unlike the Moving to Opportunity program, the families in this neighborhood are actually moving to families in this program are moving to neighborhoods that are actually even significantly safer in the metro area and are getting a lot more help so that their children can access better schools and that they can stay in neighborhoods of lower poverty. And so what we're learning is that families who are getting counseling and getting a chance to stay in these neighborhoods for a longer period of time are reaping some of the benefits of the Moving to Opportunity program, and their children are actually attending better schools as well. And just to give you a sense of what this looks like, so this is a map of socioeconomic opportunity in Baltimore, regional area. The lightest census tracts are those with the lowest socioeconomic opportunity, and the darkest are those with higher opportunity in terms of employment and school quality. Families started in these neighborhoods when they signed up for the program, and about 2,000 families have relocated since to neighborhoods in the outlying areas. So they went from these neighborhoods to those, and this gives us a sense of what's possible when we change neighborhood environment. It's sort of a sociological window into an intervention. So in closing, I'll say that on the one hand, we've learned that providing opportunities to relocate can definitely improve family and child well-being, but it's not the only policy option, and it's not viable for all neighborhoods and all families. So we also need to get community development right, and what we're hoping is that some of the lessons from these housing mobility programs can be used to inform our community development efforts, because we have a lot to learn there, and it's critical to get this right so that we don't devalue our existing communities, and we can also leverage a lot more political support for these kinds of programs. But in general, I think we can also be encouraging a number of options to give families access to affordable and higher quality housing, and we should certainly support these policies when we have any empirical evidence that they benefit some of our city's families and children. Thank you very much.
Good morning, everyone. Sometimes find myself in an unenviable position of being the last presenter, either the last thing between you and lunch or the last thing between something or after all of the wonderful presentations that have been made. In this particular instance of Michael Marmot and this great panel, you start ticking off the things that you wanted to say. Well, they already said that. Well, they already did the maps. They already did schools. So thank you very much and good night. No. I'll take my 7 minutes and start with a story. As you may know, I spent 15 years doing emergency medicine before I became a public health professional. So my story is based upon the work that I did in the emergency department. And it's a story of a young woman who came into the emergency department to be seen because of lumps under the skin in her breast. I was the attending that day, and I examined her, and of course the first thought was that she had some form of breast cancer. On further examination, there were lumps under her skin in other parts of her body which didn't fit the profile. So we continued to work her up. We admitted her to the floor and had her seen by a gynecologist. The gynecologist came in, did a GYN exam on her, and diagnosed advanced fungating cervical carcinoma. She died in 6 months. So we began asking ourselves, well, why did this woman die? And the first thoughts, because we're all medical professionals, had to do with the things that doctors do and say. Well, she was didn't have a pap smear. She was lost to follow-up. Some of those kinds of medical interpretations. And we decided to do a more thorough examination of what happened to this woman. And we found that she lived in the Central Ward of Newark, New Jersey, in the projects, on the 8th floor of a building where the elevators frequently did not work, where the mailbox covers were frequently missing, and the postal carriers often didn't even go into the neighborhood because they were afraid. She lived in a neighborhood where there were thugs who would frequently gather outside the front door of the building and demand payment to let people out of the building. The clinic that she attended was 3 bus rides away. She was a 55-year-old African-American grandmother who had to take 3 buses to get to the clinic for her examinations. This particular examination, we found she did have a pap smear that was seen as potentially troubling approximately 2 years prior. But she was seen in the clinic where the docs were frequently arrived from foreign countries where they've been recruited, which is part of the profile in many poor communities around the United States. And these docs, although clinically proficient, didn't understand the culture of the neighborhood, didn't speak the language very well, and had their own cultural biases that could have been an issue here. She had been seen getting into the clinic. The front desk clerk was probably somebody that we've all seen in one clinic or another. She was overworked, underpaid, and just a very nasty individual who treated people like dirt. The docs were seeing 40 to 50 patients a day. And when she had been seen by this male gynecologist for her examination, she was left in the lithotomy position after the examination. The physician opened the door while the sheets fell off of her leg, exposing her to the hallway. And he turned around and said, "I'm finished," and left. So then we say, the question comes up again, why did she die? Well, in the context of the work that we're all talking about here, she died because of all of the determinants that were in the way, all the systemic issues. She died because the docs were culturally incompetent, and she died because the clinic was too far away. The 3 buses to take it was a transportation obstacle. She died because she lived in the projects, locked into poverty and a cycle of childhood, teenage pregnancy. She died because of the unremitting stress that she was constantly placed under that continued to give high levels of circulating stress hormones in her system, which contributed to probably all kinds of things. So she really died because of the social determinants that were not acting in her favor and the fact that there was gross inequity when it comes to the health of this particular population. So I offer that to you as part of probably half my 7 minutes to indicate that the work that we all are talking about doing, sometimes we just have a tendency to overlook the basic elements of the causes vis-a-vis the work of Dr. Marmot. So I thought that it would be beneficial to briefly go through a couple of basic definitions that we talk about, just to make sure that because I do notice that as I travel around the country, although we've been talking about health equity, we still talk about equality, lack of equality, disparities, we have all these different concepts, and we talk about things like equity without really agreeing on what they mean. This is a long definition, but it's the one that I like because it's so comprehensive. And I only point out, as you read this, some of the most elemental parts of that it's about all people, highest attainable level of health, valuing all individuals, excuse me, societal efforts to address conditions for optimal health, and the fact that it's particularly relevant for those groups who've experienced historical or contemporary injustice or socioeconomic disadvantage. This places it squarely in the context of right and wrong and fairness, and consequently the next definition that I like to use is the one that talks about inequity. So we, and I say we in my own circle, we no longer talk about disparities, because the pure definition of disparity just means differences. And some differences are based upon the fact that, for instance, I'm a slightly older than 35-year-old male, and there's probably a 15-year-old female someplace in the room. So there are differences just because of things that are natural to human beings. So it doesn't really tell a story. But inequities says they're systemic, avoidable, unfair, unjust, I'd add unnatural, and all these differences sustained over time and generations and beyond the control of individuals. So I encourage you in your thinking as you talk about this work to think about these two definitions as the basis of your work, equity and inequity. Dr. Marmot talks about justice, he talked about fairness, so I don't want to belabor that. But just to remind you, if you want a conversation about fairness and whether it exists or not, talk to your teenage child or and they said, this ain't fair, whatever it is. I left this in because I thought about this during the debate about the Second Amendment. I wrote a column for APHA on violence prevention, and I got some nasty phone calls and emails about how dare you go against the Second Amendment of the Constitution of the United States. So I figured in this environment, I probably have a friendly ear. And isn't it ironic the number of people and the excitement and the enthusiasm that generates for people who believe in keeping guns every place, and they talk about supporting the right to bear arms, but they say nothing about the right to health, which is something that's a basic foundation of who we are. And the famous bridge over troubled waters and upstream, downstream causation of health inequities being social determinants. I always use this slide in presentations because it helps me to remember the two people standing on the bank of the river fishing as the baby floats down the river and a second baby floats down the river. And one jumps in to save the babies and the second one turns and starts running upstream after being called by his cohort. Why are you going up there? He says, I'm going up to find out who's throwing the babies in the river and stop them rather than just pulling them out, because we can pull them out forever. And pulling them out is those 85,000 African Americans who die in excess. It's people who live in poverty, people who are subject to racism, people who can't get fair housing and medical care, et cetera. Those are the ones in the river, and we need to find a way to do both, pull them out as well as going upstream and dealing with social determinants. I just put a couple of slides in about one or two of the social determinants, which we all know. I just don't have time, and certainly you have a great presentation by the master himself. But the housing photographs always get my attention. This is a real apartment in New York City. I'm from the Bronx. This is not my house, but it is an apartment in New York City. And it always points out to me how difficult it is to maintain a healthy environment when the environment looks like this. This is a woman who lives in an apartment in New York, and she's putting water in a pot to boil a chicken in the bathroom. And I look at this slide, and every time I look at it, I say, if she's in the bathroom getting water to boil a chicken, what does the kitchen look like? And how does that support her or allow or not support her in terms of providing health for her family? And then this one, again, New York City, the woman in the red is doing what we would consider a credible job of talking to mom about the signs and symptoms of asthma and when she should take her child to the emergency department. But mom is saying, well, that's fine, but what about that stuff up there in the ceiling? That's the mold and mildew that is in fact initiating her child's shortness of breath. And in the context of upstream, downstream thinking, where's the upstream intervention that says the landlord should be responsible by law for eliminating mold, mildew, moisture, and roach infestation, which are triggering the asthmatic attacks in these children who go to the emergency department as the #1 cause of hospital admissions and emergency admissions in children. That could be addressed by an upstream approach, which is something that I certainly constantly advocate for. The housing, again, I said, well, I might as well not use the housing slides because you did such a great job. But this is an old housing project in Louisville, Kentucky. This is the real photograph. Not a very pleasant place to see, to raise your children or to be healthy. That's the same neighborhood after as a Hope 6 project tore the projects down and in fact developed multi-level housing where there is no residential segregation by race or income, because you can't tell from one to another whether it's a Section 8 or a house bought on the market by cash value. So it begins to break down the segregation of housing. I think this is my last slide. For the APHA, our overarching priority for 2012, for this year, the 2012-2013, which is my administration, is #1, creating health equity. and number two, ensuring the right to health and health care, and then building healthcare infrastructure and capacity. So we have 55,000 members and 54 affiliates around the United States, and part of the challenge is getting each one of our affiliates, who are independent organizations, to see things the same way as we do as the administration, and try to propagate policies and procedures that in fact support eliminating the inequities and being about the process of pushing social determinants of health. I think I went a little over. I apologize. I wish I had more time. I'm going to take a seat now. Thank you very much.
So, wow, you each did a marvelous job in 7 minutes. And we're going to start the question and answer. And this is the part 2 where the audience can be interactive. So choose your mode of interaction, Facebook, Twitter, or note cards, and the screen reminds you. So I'm going to start off with one question, and then we'll open it up to the panel. Each of you has certainly described why place matters and how sometimes places got to be so that they contribute to the inequity. And each of you has described new initiatives that could help, certainly from a policy and legislative level. But how do we craft the messages that will empower people to join with the strategies and the things that are gonna help move communities and individual health? And maybe specific for our East Baltimore community.
So your basic question is, how do we craft the messages?
Mm-hmm.
Yeah, I think part of what we should be doing is thinking about who, in fact, has been most successful in crafting messages that get people to move and do things. There is a whole discipline of social marketing. There's a discipline of advertising. There are people who are professionals in this area. Of course, health educators themselves are trained to craft the kinds of messages that move people to do something about their behavior, and to do something about being empowered, building capacity, being about community organizing, being about the organization that moves against the development of the new liquor store in the neighborhood because the community has said this is just not right. And a part of that is the background, the underpinning of local health departments, of advocates, of urban leagues, NAACPs, non-traditional partners who agree with the positions and have opportunities to change people's opinions. But I think those are the basic elements. Social marketers, the advertisers who can be brought into the mix, and local community-based organizations.
I think that one of the things that we can do is make clear what the costs and benefits are, not just to low-income populations, but to everyone. So part of this is learning. As academics, we aren't taught how to do this very well, right? Our standards are basically, teaching to already smart people. So I think that part of it is to think about cost-benefit analyses. So the asthma emergency room example, how much does it cost if a child has several, asthma attacks in a year, relative to the cost of improving an apartment? Right, what are the cost savings to the public? I think we have, this idea, at least in the United States, that public and private goods are not the same thing. And that message can actually, I think, be brought home a lot more clearly, and especially just around concrete issues of housing. If we look at some of the very recent and quite shameful research on the effects of lead poisoning historically, especially on African American communities, and what it's cost us in terms of the cognitive development and social development of our children, I think those kinds of messages and what's at stake for our society and the individual is critical.
Thank you.
So I think of it more not so much as crafting the message, but listening to community and echoing their thoughts, because the work that we're doing both within alcohol outlets as well as other areas is really just reflecting the messages that communities are giving to us. I can't pass up the opportunity to talk about the work that we're doing within HIV, since my colleague here is an STI researcher. We're working very closely with the African American community, specifically within the BAL community. And in talking to them, we engaged them in what makes a difference to them. And to cut a long story short, the BAL community, for those of you who are not familiar, just watch the movie Paris is Burning. But the tagline that we came up with as a result of engaging the community was, have balls, get tested. You can check out our website for more info.
Okay, well, if you...
I'm not going to say anything about that. But just you made me think of the work of, you all know, of course, Thomas Levis, who's a local dude, the work that they did around identifying the cost of continuation of health inequities in the United States, something like $1.3 trillion every 2 to 3 years. So in terms of crafting messages, getting people to see a different side and getting them engaged. You know, we are engaged because of the ethical morality, the ethicals and the moral of it. There are those who are in the business community who really don't see that, but they certainly can see the bottom line of 1.3 trillion and what it does to their economic value.
Okay. So if you guys turn, I guess that's to the left, it's working. And I am going to start with the first question for Dr. Barbutt, and then we'll go to Dr. Ellen. So how could we work with community businesses, including liquor stores, to improve the selection of products and help make these existing businesses anchors for positive change in their community? The concern is that liquor stores aren't really a cause, but rather a part of an effect of other root causes.
So I'm glad that I got this question, because I didn't get a chance to talk about it in my presentation. We are very focused on retaining these businesses in the communities that they're in, because for many of them, they have demonstrated that they're community focused, and we want to take this opportunity to provide them incentives to alter their business models, right? So part of the provisions within the zoning code is you've got 2 years to either change your business model, move to an area that's properly conforming, or get out of the business of selling liquor. What we want is for businesses to stay in communities, help them with small business loans, with TA, on how they can convert the business model to either a healthy food outlet, to a hardware store, cafe, etc. Because the last thing we want is for businesses to leave these communities. We want them to stay. And unofficially, you know, what I've heard is that we are slowly having existing liquor store owners approach the planning department and the Baltimore Development Commission on how they can start moving their business model to healthier food outlets. So it's promising.
Good. Dr. Ellen, local problems require local solutions. How do we engage those who would oppose initiatives, especially around the topic of sexuality? Sexuality tied to STDs is still a very taboo topic, and conversation gets stifled from many angles.
So I can cheat because most people are very uncomfortable talking about sexuality in the first place. So that sort of is where we sit. I think we were talking about the churches, and we were talking about the balls, and one of the big things about the ball community that's been very difficult is that it's a very stigmatized community, and a lot of it is around sexuality. And the ability to engage communities in working with ball communities has always caused people discomfort because of the questions of sexuality. What we've done and what we've tried to do is meet people where they are, at least in terms of their discomfort. I mean, the abstinence-only crew that was running around crazy during the last 10 years, there's really very little to do about but vote them out of office. So there really wasn't a lot of opportunity for dialogue in that arena. But there are many people locally who have discomfort with certain topics around sexuality who will engage in a sexual health discussion if framed in the right context. And so what we really try to do is find a ground where we're not necessarily forcing, and it's particularly true in some of the communities where there's a heavy dose of faith mixed in with a heavy dose of concern, and being respectful of that faith, but also recognizing their human rights have to come into play. And as we sort of have those kind of dialogues and frame those dialogues in a respectful way, locally, and again, this is very difficult to do at a very high level, but at a local level, we found that if you're respectful of people's perspectives, that you can move things along, particularly around STDs and sexuality, but recognizing, again, where liturgy or other things may get in the way of people going full scale into where you'd like them to go.
Okay, we'll go to Dr. DeLuca. When families are able to use housing vouchers to relocate and to more affluent neighborhoods, is there further decline in the neighborhoods they leave? What are the policy and program options for turning around these neighborhood environments?
So one of the things to keep in mind is that the intervention programs that I've studied where families relocate are quite small in scope. So the Moving to Opportunity program, all told, about 250 families in the Baltimore region had the opportunity to move, and about only half of them did. So they're really small numbers. The Housing Choice Voucher Program is about 2.2 million families nationwide. So these are relatively small programs. I think that in any given neighborhood, you know, if some of the strongest families leave, or families that are cultivating community, that's certainly not a good thing. But the programs, at least that I've been studying, are not programs where families are leaving neighborhoods en masse. So it's not that mobility options and preserving these are really what's going to trigger further downfall. So that's one thing I want to say. And in part also, there's a separate issue here, which is a civil rights and human rights issue, where before we can figure out how to transform communities, families should have the right to leave them. And those options should be open for families to the extent possible. But on a larger scale, what I think is important is to think about what we do with our rental housing, right? So we've learned the hard way what the consequences are of focusing too much on homeownership in this country and focusing less on renting. So there's about a third of our households rent. And about half of these households are poor, and we don't do enough with our public policy to support renting and affordable housing options. So one thing we could do more generally is encourage landlords and property developers to maintain and produce affordable housing regionally. And then within fragile communities, especially support landlords and give incentives to them for making good business plans, preserving housing stock, and obeying already existing code. So we have very little support for landlords. We're launching a study in 2 cities this summer to try to learn more about this, because these individuals broker the geography of opportunity for our regions. And so I think these are some things. In part, housing quality itself is actually key, especially a rental stock in some of our most distressed cities.
I want to thank each of our panelists. Can we give them a round of applause?
Take my doodles off again.
Are you gonna